Anim, bonjour, hello, welcome everyone to today's virtual peer sharing and learning session, an introduction to optimizing team-based primary care. We're going to give everyone a few minutes to sign in before we start. As we wait, please introduce yourself, your organization, OHT or PCN in the chat box. Just make sure you're selecting everyone from the drop down so that we can all see who's joining. I believe by now most of you know me. For those of you who don't, my name is Leslie. I'm a focal point and coach with Rise. We have a lot of new people, I think, maybe joining today too. So for those of you who are not familiar with Rise, we are a free resource for OHTs and PCNs with the specific purpose of supporting them as they develop and mature. My colleague at Rise, Steve Lott, is also supporting us behind the scenes to ensure that things run smoothly. So if you do have any technical issues, you can try messaging the host and he'll try to help you resolve them. So welcome to our guest presenter today, Natasha Bowden. Thank you for joining us. Welcome from Stacy from ANHPOHT and Angela from Kuchicheng. In June, we shared with you a taxonomy of 9 approaches to primary care access and attachment. And over the last several months, we've gone a bit deeper into some of these concepts discussed. You can watch the recording from previous sessions on our new Rise facilitated primary care shared space. Steve has kindly put the link for you in the chat box. You will automatically be added to this group if you're already part of our population health management online collaborative. So you don't need to register if you're already part of those. We'll move you into this one as well. And please be patient with us as we add resources to this online shared space. It is brand new as of yesterday, but feel free to add your own and add your questions and comments there. It will be monitored by the Rise coaches. Also just want to note that today's session has expanded to a broader audience and will be posted publicly. The recording will be posted publicly on the Rise website. We recognize for those of you who have joined us for the last couple of years, this is a bit different. If you do have concerns with this approach, please feel free to reach out to me or provide this feedback to your coach, and we'll certainly reassess future sessions. All right, we want to ensure we leave lots of time for discussion and today's presenters. So we are going to kick off the session. To start the session, we'd like to begin with a land acknowledgement. So I'm going to pass it over to my colleague at Rise from the Northern Ontario School of Medicine, Jen Fan.
Yes, thank you, Leslie. Hello, everyone. What a great honor to do the land acknowledgement for this session. I would gratefully acknowledge that my work in my home in Toronto is located on the traditional territory of many Indigenous nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Huron-Wendat people, and Toronto is covered by Treaty 13. I also acknowledge that my place of work, Northsum University, respectfully recognize that our Pan-Northern campus is on the homeland of First Nations and Métis people. The university buildings in Greater Sudbury and Thunder Bay region are located on the territory of the Anishinaabe Nation, specifically Atikominsin Anishinaabe, Wanapati First Nation, and Fort William First Nation. As someone of an East Asian ancestry and a young researcher who work in the healthcare field, I'm grateful to live and learn on this land. I recognize that I'm a guest here and I carry a responsibility to approach my work with respect, humility, and an ongoing commitment to the truth and reconciliation, which includes listening, learning, and supporting Indigenous health, sovereignty, and self-determined priorities in meaningful and accountable ways. Thank you, Leslie.
Great. Thanks so much, Jen Fan. My name is Mike Hindmarsh, and I am a lead coach with Rise. And just to give you a sense of timing today, we're going to be doing an introduction to high-performing primary care and team-based care. We're going to have our guest speaker, Natasha, talk about social prescribing. And then we're going to have a mural board activity around optimizing team-based care to help generate ideas that you might have around how we could optimize team-based care. So the objectives for today are to learn more about what does it actually mean to create high-performing primary care and understand how practices can achieve better outcomes and ensure that patients are not only getting their clinical care, but they're getting their social determinant care needed when needed. Excuse me. We're going to also contribute to that list of change ideas that I talked about. And then, as these sessions typically do, continue to learn from each other and how we're approaching care. If you haven't seen this slide before, this is really the sort of imperative that we have had over the last 5 or 6 years, and that is to take the chaotic care system on the left and create a nice, organized, integrated, accountable care system with primary care and patients at the center of that. For those of you that have seen this, I'll repeat this slide and some others repeatedly. If you have older children who are considering tattoos, you might want to get them to use this as a tattoo. It'd be a lovely thing to have tattooed on an arm. What do we know that high performing primary care is at the heart of all this integration work, and you've done a lot of work in and around primary care, and we also know from the work that RISE has done with you that population health management is also critical to the process for a fully integrated care system. You've done all of this work. I showed this slide a couple of times before. It has been a long and winding road for you. All the work here is work that you've done. And again, I think you need to congratulate yourselves for the amount of work that you've managed to accomplish in the last 5 years. I've highlighted the attaching patients in green because that's sort of where we're at right at the moment. But please take time to congratulate yourselves. And if you're sitting with others, congratulate them for the hard work that you've done. This work, while it might have seemed a bit chaotic at times or a bit piecemeal, really hasn't been, because where you're heading with this is towards high-performing primary care. What we're going to do today is talk about being a little more organized around how we actually complete the work around high-performing primary care, but recognize that all of the work that you've done has been leading to creating a high-performing primary care sector. And you'll note that the work today that we'll talk about and in the future, it does help you fill your TPA requirements of developing a community-based plan for CDPM as well as ALC action plans, help you increase participation in your cancer screening, expand access to online appointment bookings, facilitate adoption and report on progress with e-referrals, and curate information for local services. Each of those have corresponding measurement that you'll see on the left side there, measurement around CDPM, that is hospitalization rates for ambulatory care sensitive conditions, admissions for heart failure and COPD, cancer screenings, and additional provider and patient experience. As we start moving through this primary care work, there'll be additional TPAs, I would imagine, that will come from the ministry, and there'll be additional measurements. So that's why I have the arrows there, because this is a cycling process that continually feeds itself over time. But just wanted to let you know that the work that we're about to talk about now is the next big chunk of work that is you're going to be embarking on when you think about integrating and creating an accountable care system. So what do I mean when I say, or what do we mean when we say high-performing primary care? High-performing care is equitable, culturally safe, collaborative, it's continuous, continuous in nature, especially with relationships, comprehensive, holistic. It's connected. The whole system is connected, but it's also connected digitally. The system's accessible, accountable, coordinated, and it's always improving and learning. Now, I think you can look at this list and say, you know what, I think there's stuff that's missing, or I'm not quite sure if that one thing needs to be there. And we could debate that until we're blue in the face. And so I don't want to say that your view of what should be on this previous list is not important. All I'm saying is that we've tried to capture everything that we know from the literature and from many people that have worked in this area over the years. We've tried to capture that in that list People like Barbara Starfield and Tom Bodenheimer, the folks at FLA are working on their health homes. They've all described and developed these principles for high-performing care systems. Where we want to go next is in the following slides, we're going to describe what we call a theory of change. And it's really a map of specific actions that will lead to high-performing care systems. You'll see on the right there that I've got it's called a driver diagram, but and I'll talk a little bit more about that. But ultimately, in order to create that high-performing primary care system, we have to make sure that all the primary drivers, the things that really create that system, are addressed in the work that we do over the next few months. Just so you know, RISE will be presenting work on high-performing primary care systems over the next few months, and we'll be addressing a variety of different topics, and we'll also be looking for your input in terms of the topics that you want to address. We'll also probably, and I'm just saying probably because we're still in the planning stages, have deeper dives like we did with the attachment work, deeper dives into the primary drivers of high-performing primary care. Now, I've used this concept of drivers. For those of you that are familiar with driver diagrams, this is just, and for those of you that aren't, what I'm going to be showing you is a driver diagram of what does it mean to create high-performing care. But a driver diagram basically has an aim. In this case, it's by reducing infection rates and colonization of MRSA in hospitals. The primary drivers that need to be accomplished to get to that aim are reducing transmission and reducing infection once there's been a colonization. The secondary drivers are changes that need to happen that inform the primary drivers or are linked to the primary drivers. So in this case, there's got to be decolonization. We've got to screen patients regularly. There needs to be good hygiene. There needs to be reliable precaution routines. And for reducing infection, there needs to be bundles, protocol bundles. And then those lead to change ideas that you can actually try testing to see if it fulfills the recommendation in the secondary driver and ultimately fulfilling the primary driver. So that's a very quick primer on driver diagrams. The reason I've done this is because when we think about a driver diagram for high-performing primary care, this is what it begins to look like. Now, don't worry about this. Don't try and read this. This isn't even beginning to complete. The reason I put it up is to show you how complex this work can be. The primary drivers here are really what we want to be focusing on in this discussion right now. But this is just to give you an example of how big a driver diagram can be. And here we haven't even put the change ideas and strategies that you could use. We give some examples down here. But let's look. Oh, oops, sorry. Let's talk about the primary care drivers. And I'd give a caution here on all of these driver diagrams. Driver diagrams tend to evolve over time as we learn more and as literature changes and based on feedback from you folks as you're starting to do this work. So while we've got these primary drivers here, they may change over time, but for the most part, we feel that we've captured what's involved in terms of our aim statement, and that is to create the primary care system with all of these attributes. So we talk about relational continuity, and that's how do we make sure that patients are attached to a primary care in a meaningful way where there's a continuous healing relationship. We talk about team-based care, where we need to make sure that everyone is working to their scope of practice and using population-based care to drive the clinical care of patients. That population health management approach has policies, and we need to recognize that there's work that needs to be done to make primary care population-based oriented. There needs to be timely access to care, effective and efficient skills-based governance. So there needs to be good leadership, good governance within the primary care system. Lots of you are working on that in your OHTs and your PCNs. And then we want to make sure that we have a learning health system here, a system that is continually learning from what it's doing, but also learning from the literature so that it continually improves and develops. Today, we're just going to take a look at the beginning of optimizing team-based care. So that's what today's focus is going to be. Each of these primary drivers can have a driver diagram of their own. So here's an example of a driver diagram of a high-performing primary care system. And here we have the 4 primary drivers. Again, these could change over time, but we make sure that there's coordinated care for all people and all conditions, and that we're taking a chronic disease management approach to care. We make sure that we have good referral arrangements with specialty care, and the care between specialty and primary care, long-term care in the hospital is well coordinated, so the patient doesn't have to do the coordinating themselves. We make sure that health and social services are available to meet the social determinant needs of patients, and that all team members work to the scope of their practice to make the primary care practice more efficient and ability to not only see more patients, but to make sure that people are doing the work that they were trained to do. So again, it gets very busy, even in these primary drivers that we're looking at. And again, this is not a complete list. This is part of what we'll be doing later today, is adding to that list that you see under change ideas and strategies. What are the things that you think are important in terms of primary and secondary drivers? So this is what we're looking at in terms of primary drivers for optimizing team-based care. Today, we're just going to take a quick look at one aspect of this, health and social services primary driver. And there's a secondary driver associated with that around implementing social prescribing. And some of the change ideas for social prescribing are to create a social prescribing referral process, to train providers and staff in social prescribing, to customize it to meet the needs of patients, to employ a link worker. These are all just ideas that you can test to make sure that you're delivering social prescribing to patients that need it, which meet that primary driver of health and social services are available when patients need them. So to that end, I want to introduce Natasha Baudin, who is the project director for social prescribing at the Alliance. Natasha, I'd hand it over to you to tell people a little bit more about yourself and take it away.
Sure. Thank you so much, Mike. I'm happy to be here today. So I will start by introducing myself. My name's Natasha Baudin. I'm the lead for social prescribing at the Alliance for Healthier Communities. My background is health promotion, and I worked at a downtown community health center here in Ottawa for many years. And I'll tell you a little bit about the Alliance. So we are a network of over 110 community-governed primary healthcare organizations across Ontario. So that includes community health centers, nurse practitioner-led clinics, Indigenous-led primary healthcare, and community family health teams. These organizations share a commitment to advancing health equity through the delivery of comprehensive primary healthcare. They serve populations systemically marginalized and underserved by other parts of the health system, and their clients tend to be those who face the greatest barriers to health and the poorest health outcomes. These organizations are team-based and typically deliver a range of clinical, allied health, health promotion, and social and community supports. Next slide, please. And the work of the Alliance is based on this model of health and well-being. So, and our Indigenous-led primary healthcare organizations use this holistic model of health and well-being. So our work on social prescribing at the Alliance is really rooted in health equity with a focus on enhancing collaboration between primary healthcare teams, health promotion, and community development to promote integrated and coordinated care delivery. This holistic approach in bridging the gap between clinical and non-clinical services allows Alliance members to address clients' diverse needs in a comprehensive, client-centered way. We also have a health equity charter that guides our work, which is a living document oriented to advancing health equity through a human rights and social justice approach and to driving change at all levels, systems, policies, as well as organizational and individual practices. So next slide, please. So I want everyone to take a moment and think about something outside of your healthcare, outside of your clinical healthcare that supports your well-being in your life. Is there something aside from going for your checkup at the doctor's office that helps support your well-being? And if you feel bold, you could even put it in the chat if you're feeling brave. Right, family and friends, going for a hike, spending time with our pets, All of those things contribute to our well-being. Oh my gosh, you guys have great examples. So moving on to the next slide, we know that when we look at the social determinants of health, it's the conditions in which we are born, grow, work, and age is what determines our well-being. And so we look at income, social exclusion, community belonging, food security, racism, colonialism. When we look at all of these things, they definitely contribute to our health. So the aim of health equity focused social prescribing is to address many of these factors by providing social and community supports, in addition to building trust with clients who might not have regular access to primary care. And so just a general definition. So I always say that social prescribing is connecting people with non-clinical programs and services that support their health and well-being. But it's also an intentional, structured way of connecting people with those services. And it will look different for each community depending on resources and supports. And we feel that health equity is a cornerstone of effective social prescribing. So it means removing barriers to access for clients. And just to give a couple examples of what social prescribing might look like, it might be a connection to physical activity, food security, it might be access to the internet, it might be bus tickets, it might be income security, could be arts and culture, nature-based activities, and social connection, just to give a few examples. And so at the Alliance, these are the 5 key components of a social prescribing pathway. So we have a client, an individual with social and medical needs, interests, and gifts. We have a prescriber who is the healthcare provider who identifies those non-medical issues, loneliness, low-level anxiety, low-level depression, no sense of belonging or sense of isolation. That provider makes a social prescription referral. Then we have a navigator or a connector who could be an individual, it could be a health promoter, it could be a community developer, it could be a community health worker, or it could be a case conference or a team that receives that referral, spends time with the individual to connect them to appropriate resources based on self-identified interests and needs, and supports their journey to well-being, which results in a social prescription. So the individual is connected to social and community supports with an invitation to engage, co-create, and give back. And along the whole journey, we have data tracking so that the client journey is followed. There's follow-up and improvement through a learning health system. And just to give an example from my center, when we were implementing social prescribing, what I heard was, oh, we already do this. We already have integrated care. We already work with our non-clinical colleagues. But the difference was being able to enter it in the EMR, track it, and evaluate it. So for example, it's the difference between a physician at my center saying, oh, just go down the hall and check out Natasha's stress reduction program, and like not really knowing if the client made it or what the results are. But when we put that referral into the EMR, the physician can easily look and see, oh, the referral was received, the client was registered, and the client attended all 8 sessions of the stress reduction program. And then when the client comes for their annual checkup, the doctor was able to give me the feedback that, oh, as a result of the client's anxiety being greatly reduced, we were able to get through that annual exam much faster, and it saved me time as a doctor. And what I saw at my center, the greatest improvement was that interdisciplinary collaboration, having clear, easy ways to refer. And so this is an example. One of the advantages that Alliance members have is we have a shared EMR and we have shared tools. So this is an example of what social prescribing referral might look like. This is what we use. So the physician or the nurse practitioner or whichever, like it can be any staff in the health center who can make a social prescribing referral. It's simple. They just tick off social prescribing client. I'm thinking, the client has been talking about being lonely. So I'm thinking as the physician or as the nurse, maybe social activity. It's easy. And then they send the referral over to the health promotion team that then will triage it and then sits and meets with the client and has a bit of a longer conversation. Your doctor thought you might be interested in coming to the coffee drop-in, but what are you most interested in doing? Next slide. And this is how we chart our social prescribing work. So we have a standard encounter form. So visit for social supports, family supports, social isolation, low income, food security. Those are some standard ENCODEs that we use. slide. And so just to share, we have over 80 of our member centers have implemented a formal social prescribing project. This map is from our Social Prescribing for Better Mental Health project, where we worked with 28 different sites across Ontario, just to show you the diversity of sites that we're working with. And then just a note on link workers. So they play a key role in delivering social prescribing by spending time with clients to hear their needs and understand their interests. Most importantly, they shift the focus from what's the matter with you to what matters to you. They take a holistic, community-focused, and evidence-based approach to people's health and well-being to connect them with appropriate community groups. So just to give another example, I had a referral for a client, and her first connection was we had a creative writing drop-in at my health center. So she started off being an attendee of the creative writing group. And then after about a year, there was an opportunity to become a peer leader. And we supported her in taking this peer leadership training. And then she became one of the co-leaders for the group. And then eventually she wanted to start a BIPOC exclusive writing group. And that became her space. And now that person, somebody who was very bright, but was not reaching their full capacity, she now leads writing groups like 5 days a week. And she's really found a real path for herself. And there's something about having meaning to your life and that kind of impact. And I could have never predicted, and I don't think the physician could have predicted from the first meeting that would be the path she would take. So you spending that time with the client and helping them connect with their interests can be really impactful. Just a little bit of our evidence. So when we did the pilot back in 2018, 42% of providers reported that they observed a decrease in number of repeat visits among their clients who participated in social prescribing programs. And just at my center, what we did was we looked at high frequency users of primary care who had low-level NCODEs such as low-level anxiety, low-level depression, loneliness, or isolation. And with the provider's permission, we targeted those clients for social prescribing, and that's where we saw the decrease in primary care visits. So people were not decreasing their need for clinical attention at those visits, but rather the ones who were coming in every week to talk about feeling lonely or for some of those things that are not as well addressed by our clinical colleagues. So next slide. Our vision at the Alliance is one of a neighborhood health home. I just thought I would mention this. So a neighborhood health home would be nestled within neighborhoods serving people within that region or a large neighborhood. It would ensure that people have barrier-free access to interprofessional teams, health promotion, and community supports. Our vision is that communities are responsible for governance and are the decision makers for what is best for their community. Along with community governance, this includes a community-centered approach to co-design principles with the communities to ensure tailored services and accountability to those that the services are being planned for. The neighborhood health home would be supportive and collaborative and aligned to a population-based approach that is grounded in health equity. So we would envision that the entire community is part of this neighborhood, not just the clients that walk through the doors, but based on existing team-based models and creating new ones where necessary. So key to this model are collaborations of providers that are working to full scope of practice to ensure that all people receive care when they need it, that is seamlessly linked across providers, teams, and settings. And this includes all sorts of providers and ideally access to a link worker role as well. And I just wanted to share a couple examples. Whoops, sorry. I forget that I'm not controlling. I'm like, yeah, that's okay. So just to share an example from Guelph CHC, it's really important for the link worker themselves as well as their colleagues to understand the scope of work. So I like this example from Guelph Community Health Center. So social prescribing is, their prescriptions are proactive and upstream. They are non-crisis and non-medical. So not reactive responses to crisis. They do not address immediate complex health or social needs. So really good examples here. So, when I started off in that role, I would get like requests for foot care, requests for like a housing crisis. And fortunately for me, I knew where to refer. So for example, I had colleagues, I had community health worker who could support replacing ID, could support Ontario Works applications. I could refer to counseling and mental health if it was outside of my scope. And next slide. And this is just an example of defining the scope for the public or for the clients, the potential clients. So this is an example from Grand Bend Community Health Center. So what is social prescribing? It offers support beyond medication, learn a new skill, participate in a new activity, improve your mental and physical health, meet new people, increase self-confidence. And then they have some examples. So this is a great way to put it out there for people in the public to kind of refer themselves to connect with any of these things if there's interest. And the place where we saw the greatest improvement in self-reported mental health was when someone was given a role to volunteer, no matter how small that role was, whether it was filling the bird feeder or running a group. Huge impact in self-reported mental health for the clients. Just wanted to mention a little something about asset mapping. So every community has assets, resources, programs, people, or places that a client can be connected with. So just wanted to mention that an asset map is an iterative and living tool. So you probably have some sense, or some healthcare centers will have some sense of what resources exist in their community, but an asset map is a great way to make sure those connections are kept. And there's also regional databases like Ontario 211 or Ontario Caregiver Organizational Hotline as options. And there's, just to reiterate, these are partners that are available to anyone, anywhere in Ontario. 211, Ontario Caregiver Organization, and the Older Adult Centers Association of Ontario can help you connect with a seniors active living center in your community. I'm going to tell you a little brief amount about our social prescribing journey at the Alliance. So I previously mentioned our pilot started in 2018 with 11 different CHCs across the province, and that's where we were able to demonstrate that this model could work in Ontario. Links to Wellbeing started in 2021 and continues to this day, social prescribing for older adults, and our goal is to have seamless referrals from healthcare settings to community settings, such as those offered by the Seniors Active Living Centers. Social prescribing for better mental health was an 18-month project funded by the Public Health Agency of Canada. And we worked with 28 different sites across Ontario using quality improvement coaching to support them in creating and maintaining social prescribing pathways. We also were able to create an online learning modules for health equity focused social prescribing, which are free and available to everyone. And another project is our Black focused social prescribing, which I thought I would take a little deeper dive into just to give you a sense of what a project might look like. So this is a social prescribing model grounded in Black and Afrocentric values and principles, making social prescribing culturally affirming to improve healthcare experiences and healthcare outcomes for Black people and Black communities in Ontario. We worked with over 4,000 clients at 4 different sites across the province. And out of those clients, 1,600 received social prescriptions. Next slide. I never know how much I should talk about each slide, but so to ensure that this project was grounded in those cultural perspectives, values, and lived experiences of African, Caribbean, and Black communities, we used the principles of Kwanzaa to guide the work. In particular, Nia, which means purpose, Kujichakulia, which means self-determination, and Ujima, which means collective work and responsibility. So at every process, every decision, we would come back to these values, ensure we were thinking collectively, ensure that every aspect related to self-determination. So if we ever needed to order catering, eat at a restaurant, we were always supporting Black-owned businesses, and we always kept coming back to our purpose. And just to share some of the results, 89% of participants reported feeling a stronger sense of belonging within their community after participating in Black-focused social prescribing. 90% reported that their trust in service providers had increased after participating. 87% felt their health and well-being had improved. 40% participated in culturally affirming wellness activities, and 30% engaged in mental health services. And here is an example of a Black focused social prescribing health fair, which took place put on by Black Creek Community Health Center. And so it was in the mall, there was music, there was food, it was very festive. And while you were there, you could also get your blood sugar tested, you could get your blood pressure tested, you could find out about different kinds of health services. And so there's no wrong door to entering in to receive your primary health care. And what I really liked about this health fair was they met people where they were at, they came into the community, very friendly and very fun approach. And maybe I will just take one moment to share another client journey from Black Focus Social Prescribing. So we had a client at our focus groups. We had these very fun, very participatory research focused focus groups, food and very arts based. And we had clients share their stories. And one story that really stayed with me was a client living in a shelter in Ottawa, and she was about to graduate from a program, but she had not been able to keep up with her hair care, and she was not feeling very confident. Her self-esteem was low, so she wasn't really leaving her room at the shelter, and she wasn't planning to go to her graduation. But she heard about Somerset West Community Health Center offering a hair drop-in, and she went to the hair drop-in, and she said, "Imagine my surprise. I did not even have to explain about Black hair. Not only that, I didn't have to explain about my culture. The hairdresser knew my home country. She knew my language." She said, "For the first time since coming to Canada, I felt at home." And then through the hair care, and she was able to go to her graduation. And through that hair care connection, she was able to get connected to some food security programming that Somerset West was offering, which led to her being able to eventually connect with primary care and getting some of her health needs met. So as much as social prescribing is a referral sometimes from primary care to the community, it can also be for those hard to reach patients who perhaps for good reason have a mistrust of the healthcare system. It can also help connect them back to healthcare. Just amazing story. I wanted to share a few little quick examples of how social prescribing is already being implemented across Ontario. So I know OHTs are implementing, hospitals are implementing. There's an amazing program right now with Healthcare Excellence Canada. The community paramedic program and they are working with their community health center to refer, the paramedics are referring to the link worker at the CHC. And then I just like a personal one that I was made aware of is a medical clinic where it's just physicians connecting with a mental health resource in the community so they can collaborate to really get holistic care to their clients. And I think the OHTs are so well positioned because you can start with the partners around your table and those can be your first connections. I mean, I'm sure you already know that. Okay, so now you're really excited and you're really passionate. You want to start implementing social prescribing. So here are some resources to support you in doing this. So this is a great tool that we developed with the Center for Effective Practice. This is a resource in particular for health professionals, so doctors, nurse practitioners, and nurses, and other clinicians. So feel free, it's free and you can feel free to access it. I also wanted to mention we made 5 videos about implementing social prescribing in different settings, including nurse practitioner-led clinics, community health centers, francophone centers. So feel free to peruse those as well. And then I mentioned the online learning modules. So the modules include getting buy-in from an interdisciplinary team, co-designing a process map, using the EMR to track data, creating and maintaining an asset map, training the providers, meeting with clients, working with volunteers, pilot testing your new social prescribing program, and using data to drive improvement. So those are free and you're welcome to access them. We also have a bi-monthly social prescribing community of practice open to anyone in Ontario. And you can find that on our website. And next slide. Yeah, just put a QR code for our online learning to make it easy for you to access. It's available in English and French. And we do have one module that is specifically designed for clinicians, which is eligible for 0.5 CERT Main Pro Plus credits. So feel free to promote those. We have final reports we can share. And in particular, I think the link workers work document can be really helpful in making a case for that role. And then these are my calls to action. So we are really asking for link workers to be included in plans to create primary care attachment for people in Ontario, providing those link workers for all interested healthcare providers, and advocating for a neighborhood health home. And thank you. That's my presentation. I think I whipped through it pretty quickly, but I'm happy to answer any questions you may have.
That was fantastic, Natasha. It's so great from my perspective. Um, I've read a lot about social prescribing, but I've never seen it put into action like the way you've done it. So
Oh,
I think
thanks.
it's really helpful for the teams to see how it can be done. The resources are fantastic. I haven't been able to monitor the chat, folks. Do people have questions for Natasha?
I don't see any questions in the chat just yet. But I would be interested, Natasha, you mentioned that one of the change ideas that teams can think about doing, you mentioned, asset mapping, so understanding the available resources in your community. Can you speak to some of the other key change ideas teams could consider, or when you think about what the biggest facilitators are for this work?
I think the biggest change factor that I saw was that everyone in the whole organization is on board for the change. So it's not just the link workers role. So we really like at my center, it was leadership was involved. It was the clinical side, it was the non-clinical side. We were all on board for this, and we had a horizontal team, so people from every section of the organization who kind of made the decisions and moved it forward. So that was really important. Having it integrated in the EMR and having the link worker as part of the care team so they can also access the EMR and they can, there's continuous feedback. Um, I don't know, having champions, like having a clinical champion. So it was really helpful for me when I went over to the primary care side and I used my health promotion language, but I had a physician and a nurse who were champions, and they could like translate it so that it was well received by their colleagues. And also like starting small, like it doesn't have to be complicated. So start small, like you can start with a 2-on-1 referral. And I would also say make the referral as simple as possible. So the referral form is just like
Yeah.
2 clicks and they can send it. Like at first we were like, oh, we'll make an asset map and the physicians can look through the 429-page asset map and they can put, and it was like, no, let's like keep it as simple and clear and understandable. And then you're continuously reminding people that this exists, like reminding your colleagues at the center, your public, like everyone, kind of making sure everyone's aware of it.
Yeah, that was a question I was going to ask also, Natasha. Many of these teams have done asset maps of all their community resources, including their social service resources. So, for let's say, I know you've been working with CHCs, but let's say for a provider in a small group practice. What's a way that they could get started? Maybe they have access to a social worker, maybe not. Any suggestions for how they can get started? Because what I don't want people to do is look at all the fantastic work you've done and say, "Oh, I can't possibly do that."
Uh,
Um,
so even a solo doctor with no colleagues can always make a simple referral to 211, the Older Adults Association of Ontario, or Ontario Caregivers Organization. And I have great stories from solo docs who were like, I was working with a client who had diabetes and it had been well managed for many years. All of a sudden, it's being really poorly managed. His sugars are all over the place. And he's like, I could have just changed his medication, but I took the time to ask one more question. Has anything changed in your life in the past 6 months? Well, yes, actually, my elder parent just came out of the hospital, has very complex health. I've taken on about 20 more hours of caregiving than I used to, and I'm not able to like get that exercise in or eat like I used to. So just asking that extra question prompted a call to the Ontario Caregivers Organization, caregiver support, which led to caregiver support for the patient, but also respite and activities for the older adult as well. So sometimes it's just asking one more question. Um, and like I think collaboration, where this is where I feel excited about Ontario Health Teams, and I think there's so much potential for collaboration and sharing resources. Another example, like the one I put in my slide, that's Richmond Clinic in outside of Ottawa, in the rural area, partnered with Western Ottawa Community Resource Center. Western Ottawa had mental health services with no wait list. The clinic was seeing a lot of mental health issues for their patients, but they didn't have a social worker, they didn't have a counselor. So they partnered together and they sent their mental health intake worker slash link worker to the clinic 1 day a week to support this need that the doctors were seeing. So sometimes it's like partnering, making a meaningful partnership with another organization in your community.
Um, I'm still looking for people's hands to ask questions. Do people have questions? I've got at least another one, but I don't want to
I love
co-opt the
answering
time.
questions. Yeah.
Anyone want to jump on and ask Natasha a question? Okay, I'll ask my question. Um, so in my years of working in primary care, when you introduce new concepts and new things to do in primary care, quite often the first thing you hear, and legitimately so, is I don't have time to do this. I don't have time to ask that question, and it's going to open up a hornet's nest for me. Um, is there suggestions about how they can go about doing that without becoming overwhelmed by the patient's social needs?
Oh, right. When you're meeting, like, so sometimes when you meet with the patient, you say, I don't even want to ask these questions because I don't
Right.
have a solution for them. Right. So I think everyone can like relate to the experience of feeling seen and feeling heard. And I think that's so important so if there's someone in the team who can take that extra moment to sit with the client, and I think about as a health promoter, I did, smoking cessation. And so many times I would say, okay, well, like, what brings you here today? And the client would say, my doctor really wants me to quit smoking. And I'd be like, what do you want? And they're like, I want to smoke for the rest of my life. And it was like, okay, what can I help you with here today? And it's like, okay, maybe you're going to start reducing your smoking because that's your goal. And maybe you also want to save some money. And maybe you also want to live a long life. So let's talk about that. So just to say, like, giving that space for the client to be seen and heard and to kind of focus on their goals or to like get at those goals with them, I think is really valuable.
Yeah.
I, yeah. And
Yeah.
having someone to refer them to, like to think, okay, I've got like 211 deals with a lot of different things. They have a huge asset map. I've got Ontario Caregivers Organization, and I've got the older adults. Like those are three things I could start with, like start small and build up from there.
Yeah. And your data also shows that it is saving time for providers, that some of those patients that are coming back continually are not coming
Yeah.
back as often because those needs are
Yeah.
being met, which is fantastic.
Yeah, we heard stories from clients that were like, "Oh, I feel so bad, but I'm not able to make my doctor's appointment because I'm not really able to talk about loneliness anymore because I've got so much going on now. I'm going to coffee group on Mondays, and those are kind of the stories we want to hear, right?"
Yeah.
And I'll just say, like with the link worker, often people ask me what the best, most important skill or training that the link worker needs, and so it's always like being trusted and knowing their community and being a trusted person in the community. So when I think about the Black focused social prescribing, our link workers, our navigators were folks from the community who knew the community really well and were able to build trust with, like, were a trusted relationship with the clients, and they were very, very thoughtful about every single prescription they made. So, is the Art Gallery of Ontario a good culturally affirming experience? Only if they've got Black artists up this month, and we know that they'll have a good experience. So they were very thoughtful, and that's kind of was like the secret sauce that made that project so successful, was having these amazing navigators who really knew their community and were really advocating and going to bat for their clients.
Um, yes, Kate Pataki has asked a question. Have you conducted an evaluation on the program? I'd be interested in seeing one as we are implementing this in Chatham, Kent. Interested specifically on the questions that were asked.
Yeah, we have done evaluations for all of our social prescribing work, and we do have our final reports up on our website, and I'll put the links up in the chat. Um, so we always look at like I'm not sure what kind of um, yeah, I'm happy to share what we did. Like we often ask about self-reported mental health, physical health, sense of belonging, like isolation, loneliness. Those are kind of the areas that we tend to focus on, as well as that like trusting the healthcare provider. With the Black Focus Social Prescribing, we did two different kinds of evaluation. We did a developmental approach, and we also did a participatory evaluation. And the participatory evaluation was incredibly empowering because we invited clients to become, we called them our peer experts, our peer evaluators, and they defined what success of the project would look like for them and if we were meeting those goals. And they became community leaders, and that's why we had focus groups and we were like, sorry, we have to limit it at like 25. And then we were like, sorry, we have to limit it at 35. Like, I've never had this experience with focus groups where it's like the hottest thing in town. People really want to come to the focus group and tell you about their project. So I'm happy, like, feel free to reach out to me. I'm happy to talk about our evaluation. And our evaluation specialist, Josephine Pham, convenes a social prescribing community of practice, a small community of practice where people share their different evaluations and how it's going. So also happy to share that. And like I said, the community of practice is a good place to also chat about social prescribing evaluation.
Great. And you got a thank you from Kate. Well, Natasha, this has been wonderful. As Leslie noted in the chat, the group's a bit quiet today. They've just come off a very brutal expression of interest process. So everyone's pretty tired, but I think it's not lost on anyone the amount of resources that you have. So when folks are ready to start this work, they've got not only the resources, but hopefully they'll come to you and to get guidance on how to implement some of the tools, so on and so forth. So we really appreciate having you, and thank you so much.
Thank you so much for having me as well. And I'll just put a few links in the chat. So really a great to be here. Thank you.
Oh, Lori's got a question. Terrific.
Yeah, sorry, Mike. I was a little bit slow here today. One of the things we heard in the deep dive in the last couple of weeks was, with that wrapping up of the bow supportive attachment step in your attachment process, one of the things that people are struggling with is when you don't have a primary care team or provider to attach people to, that, so what can you put in that step of supportive attachment? And I guess this is less a question, but I'd love to hear too if you think, Natasha. I think this is, examining social prescribing as including it in your supportive attachment step can be really powerful. So if you don't have the resources or you don't have your primary care provider or team to attach to, can you attach people for these kinds of things? Yes, of course, they can't touch the clinical aspect of it, but can you provide care and services to them? You'll only know that through your intake process with respect to needs. But I sort of see that this is a really powerful tool or to broaden your care, and especially in that supportive attachment, because we've been talking about how do you do that when you don't have a team to attach to, especially in the North. Brianne, love to hear what you think on that. But that was just something I'm thinking about in terms of connecting it to the work that these folks are all working on.
I don't know if did you want me to speak to that a little bit or?
Sure.
Yeah. Like I think about when I was working as a health promoter, we had rostered clients who accessed primary care, but I could also see anyone in the community. So people who didn't have primary care, who were maybe just going to walk-in clinics occasionally, could come and see me as a health promoter for smoking cessation, physical activity, healthy eating. And I was able to connect them to all kinds of programs and services through my work as a health promoter, even though I couldn't connect them always to a family doctor, but I could connect them to lung health. I could connect them to lots of other programs that were supporting their health. And when I think about like one of the examples, the community paramedics program, where in Northumberland, the community paramedics can refer to the link worker at the CHC. So it's not, it's still, and I also think about wait lists too. So not exactly what you were asking about, but for example, we had very lengthy wait lists for counseling at my health center. But in the meantime, we started an overcoming anxiety and depression group that was open to everyone. So while you're on that, 3-month wait list to see a counselor, you can come to this skill building group, overcoming anxiety and depression, like so that you're not like waiting and doing nothing. You can kind of start to work on it. And we implemented many different groups like that were kind of like, as you wait for this goal, there's things you can be building and skills you can be building, you can be and peer support and all of that that can kind of support you in that time.